Welcome to Fertility, Hormones and Hope, the podcast where we bring you the experts within the fertility and women's health space to answer your most asked questions and help bridge the gap between holistic care and evidence-based science. I'm Jen Walpole, a BANT registered nutritionist specialising in fertility and pregnancy.
And I'm Richa Puri, nutritional therapist, also specialising in fertility and a women's health specialist. So today on the podcast, we're delighted to have on ScreenMe co-founder Golnoush Golshirazi. You have a PhD in molecular biology, and we just want to know how this journey with your PhD and what you've studied led you to co-founding the company ScreenMe.
Yeah, thanks for having me. I'm really excited to be here. Gosh, it's been a long journey, I think. When I went to university and thought that and people have asked me, at what point in your life do you think I'm gonna do vaginas?
Yeah.
I didn't. It wasn't like.
I'm glad we're going straight into it with the vagina.
Beat around the bush, excuse the pun.
I mean, it's not like I woke up one day and thought this is the field I'm passionate about. Or it wasn't, not on my mind at all. I was always interested in health and molecular biology. Even though everyone said do medicine.
Really?
I had the grades to do medicine. I didn't want to because I always thought that there's more to be done in the research than be a doctor. And so I did. I was more interested, so I did that. And even when I wanted to do my PhD, I still wasn't sure what to do it in. And I actually picked gene therapy, and because I thought precision medicine was very cool and you could change people's lives, really.
Could you really quickly explain what precision medicine is? Because I think that's really, really important to touch upon.
Yeah, maybe more so, I think as we're going forward in time, the concept of healthcare is changing and the way we treat people is changing, and medicine is becoming more personalized. So rather than treating everyone in a batch, we're talking more about personalizing things to the need of the patient. And then out of that comes many different fields, including genomics, including gene therapy, and go on. It's a massive field. And I think for me at that time, I thought, well, there are people who are born with a really bad deck of cards. It's not their fault. And how can you help them? And I remember at school, my teachers telling me, well, they've got this genetic disease and you can't do anything about it. And I thought, well, surely there is. And I came across the field of gene therapy specifically. And I thought, well, you go and you can change it. And that's where the world of genes and genomes and next generation sequencing and all of that opened up to me. But whilst I was doing all of that, I was also a young adult and a woman who didn't have it easy. I had a really hard period from the point my period started at the age of 12. I remember my first period. I thought I was dying. They thought I had to get my appendix out because of the amount of pain. No one realized I'd started my period. It was just that crippling of a pain. The moment that I went into the bathroom and there was blood, everyone was like, oh, it's fine. It's just the period. You're not dying. It wasn't fine. It was the start of a very long, painful journey. And from period pains onto recurrent infections and more complications as I got older. So I had it hard as a woman. But even though I studied molecular biology at Cambridge. I went on to I was doing my PhD. I was educated. I could read papers. But I still didn't know anything about really my own body as an individual. The healthcare system failed me on multiple occasions. And then I was very accidentally diagnosed with endometriosis. And after that, I actually tested myself using NGS because I had access.
Wow.
Of these recurrent infections. I wasn't testing. My cultures were coming back negative.
Yeah.
And I was being told, oh, well, there's nothing there, but I had symptoms. And it just didn't make sense. So that as a biologist, as a molecular biologist, as far as I was concerned, either the tests were wrong, or there was something more physiologically wrong that wasn't being picked up, you know? I was like, well, there can't be nothing there. It's either there's some inflammation, something's wrong with me. I'm not crazy.
So this is
that was the start.
the culture test that you're referring to.
Yes, so there would be the culture. So
yeah.
that's what's usually used
Yeah.
when you go to the GP, etc. You're usually swabbed and cultured. And this is when they try to grow bacteria on a dish in a lab. It's really hard to do that.
And
Right?
not everything grows, does it?
Absolutely not.
Yeah.
So it's really hard to do that. Not everything grows.
It's out
needs
of
to be really
its-
high levels of bacteria sometimes. Things can go wrong really easily. So getting a negative, a false negative is
Quite
common. So
and that's because the bacteria is out of its natural environment. Is that what you would say?
Yeah, I mean, you know,
The
bacteria
exposure
grow,
to oxygen and other
what
things.
it eats, the oxygen levels. There's so much that depends on how bacteria grow, and just culturing them isn't very easy. Some of them is, but not all of them. And I found out that I had a huge atopobium overgrowth. I had very low lactobacillus levels, so my vaginal microbiome was completely screwed up.
And this was from the NGS testing.
Yes, it was.
So this is a really nice segue to talk about the testing, because I know you've mentioned NGS a couple of times. So can you just explain to the listeners? So we've talked about kind of going to your GP,
Yes.
doing a culture or a swab, getting a false negative, and the
Yes.
difference between that and what ScreenMe offer, which is the next generation sequencing. So let's have a chat about that.
So next generation sequencing is the gold standard method that's used in research when looking at the microbiome. So the majority of the research that you read or data that you see that's being collected, whether it be the gut, the vaginal, the oral, the uterine, the majority is now using next generation sequencing. And what that means is that instead of screening for a selected panel of bacteria, we actually extract the DNA of the bacteria, and then we use genetic sequencing to sequence that DNA.
So
Just
interesting.
like you do with human DNA, using the same machines, but a very different method. But we're actually using the DNA. And that DNA, once we sequence it, it can then tell us which bacteria are present in the sample and at what levels. It's very sensitive.
Each bacteria has its own sequence. Is that right?
So DNA,
Specific
right?
sequence,
Exactly.
yeah.
So it's like DNA, like it's the DNA. So like the DNA of any human, if they take your DNA, they can sequence it and they can know it's yours. Or they can know it's definitely a human DNA, right? So it's the same with bacteria. We use 16S, which is specific to bacteria, and ITS, which is specific DNA to fungus. And you sequence that, and it can tell you exactly what's there. People often ask, what do you screen for or what do you test for? That's probably the most common question that you get. And because obviously they're not used to the concept of actually we're screening for everything that's in the sample. And we're going to take the DNA, we're going to sequence it, and we're going to get the list of all the bacteria
Comes back,
that
yeah.
hits back.
And that's the biggest difference, right?
Yes.
Because when we're talking about swabs, often it's a method known as PCR.
Yes.
And it's basically just looking for specific strains of quite common bacteria.
Right.
But we know even within a bacteria species, there's different strains, but they
Yes.
might not be looking for those specifics. So getting the full picture, just explain to us why that's so important versus just screening for specific strains.
So we have the culture, which we spoke about, so that the growing bacteria in a plate. And that's a really cheap, fast way of getting a quick idea of what's going on.
It's been around for a really long time,
Oh,
hasn't it? And so that's what people are
long
just
as time.
used to.
Absolutely.
And so now kind of new methodologies coming through. It does take, I work in the NHS.
Yes.
It takes a long time for things to filter through.
Of course.
And so now when these new concepts come about, people are a little bit like weary, hesitant.
And they should be.
Yeah.
Right? change is scary.
Yeah.
Especially change in a sensitive field like medicine or healthcare.
Exactly.
So there's nothing wrong with the old methods. Culture is useful and it's important. It's cheap
and
it's
quick.
fast.
It's a quick turnaround as well.
It's a great thing to have at hand. Then we have PCR, which is more sensitive, more specific. It's diagnostic, which means that it's been tested, proven,
shown to be
accurate. All the paperwork and the bureaucracy has been done. Yes. So and that's important. So the PCR is there to diagnose specific infections.
Yeah.
But it's limited.
It's what you feed in, isn't it? So it's this list of bacteria, which are usually the most common bacteria that we're aware of.
Yes.
Which are then put into the machine, and if it's like a game of Snap, isn't it? If you're
a bit, you're giving PCR is. So you still use the genetic material of the bacteria, but what you're doing in PCR is, I'm going to use like some sort of more understandable analogies, I guess, is you're giving the machine little keys for each of those bacteria. And so those keys are specific to those bacteria, and so it will find them in a way. And we have two types of PCR. One is very quantitative, one is qualitative. Mm-hmm. The quantitative just comes up with a band and tells you, well, this is present. Whereas we have quantitative PCR, qPCR, which doesn't just identify it, but it also actually quantifies it. How much of this bacteria? It's an absolute level that it gives you, and it's based on an internal threshold that you give it. So these are good tests. They're better than culture when things are complicated. They're diagnostic from some labs. There are research labs that do them as well, and you can't call them diagnostic, but in essence, they're testing for the same thing. And so they are good tests. They just don't test for everything, and they're not doing relative testing. So they're not actually microbiome tests. They're panel tests, and they test for specific infections, and they are very useful. Again, they can be faster than NGS, and they're cheaper than NGS as well. Yeah. Which I think they're a great thing to use for a retest, especially if you have a specific infection. And then you have NGS. It's more expensive. It's a lot more comprehensive. Gives you a lot of data. It takes longer to get results. And so as we go between these tests, things get more complicated in terms of data that you get. It's longer, it's more expensive. And it's really important to know which test you need. I founded ScreenMe not because I was out there to start a startup. I had a problem. I found out why I had this problem. For me, it was a huge question of why aren't we making more precise methods or, other just science. Why aren't we making science accessible to those who need it? I didn't want the doctors to tell me they know what's wrong with me or that they can fix it. I just wanted to help. Mm-hmm. I just wanted answers.
So with the NGS screening, did it help you get the answers and be able to resolve?
To do something, right? Yeah. I knew what was wrong. There wasn't an overnight answer.
No.
And it took a long time. And it's up and down. Sometimes it's still down.
Yeah.
So it's not, but I have data about my body. I know how it's working. I know what the flaws are. I know what the strengths are. And at least I can do things to help it.
Yeah.
I'm very aware that there's a huge gap in research, in therapeutics, in diagnostics when it comes to women's health. We just don't know enough. We don't have enough. The vaginal, I'll call it the reproductive microbiome, the uterine, the vaginal, the seminal, is like a black box. No one really cared much about it in the past, at least not enough to shed some light on it. The vagina was always this hole that people just stuff things in or stuff things out or push things out. It's just a hole, right? Even products that are made for vaginal use, be it toys, or they're not really tested properly. No one looks at the impact of it on the ecosystem in the vagina. Everyone, no one thinks that's important. Whereas actually the vagina is an immune system. I wasn't sexually active when I was having these problems. Everyone assumes that it's, if you're sexually active. Exactly. It's not true. There's so many factors, and it's an immune organ. It's not just a hole. It's it's like the gates to your reproductive, to your pelvic floor. It's a gate.
Fertility.
Everything.
And we're going to get into this as well as we go through. And before we do, what I just wanted to understand. So you started with vaginal microbiome testing, and then obviously you've expanded the range. And I love that you talked about the reproductive microbiome because it is, when we're talking about fertility, it's a shared microbiome. But then you've again more recently introduced the uterine. So let's just go through each one briefly. Yes. Was it the vaginal you started with, and then how did you move into the other areas?
Yeah, once we actually were ready to go into the reproductive microbiome, we started with the vaginal.
Yeah.
And that the reason for that was the vaginal microbiome as a field is actually very well researched. There's a lot of data. We know what is considered healthy in a woman between post-puberty until menopause, I would say.
The
reproductive sex. Yeah. And so that was straightforward. We knew what we were looking for. We knew what healthy is.
And there was already tests existing, like you said, the PCR.
Oh yeah, absolutely.
And that was looking at vaginal
kind of ecosystems. And the vaginal microbiome testing isn't so in the US. People had been doing it. There were other companies that had done it. And in research and science, as far as we, my co-founder, Dr Golnoush Golshirazi, and myself, as far as we were concerned, there wasn't any doubt in the importance of that in the data. And so we went that way. Both of us are scientists. We're not. We want to go with science. We wanted to make sure that we're doing things the best way in terms of the methods used, the quality control used, everything. We always went for what we knew to be gold standard. We didn't cut corners. We didn't cut costs. We're still suffering for that, but so that we thought vaginal was the way, was the one to start with.
That led the way.
Absolutely.
And was that more because of your own experience?
I guess that had a part to play.
Yeah.
I mean that opened the door, right? So because of my own experience, I went down that path. I knew a lot more about it. But also because when we did look into it, scientifically speaking, it was the safest one.
Because there was a lot of data,
a lot of ground to build on.
And when we were looking at the research as well, I mean, the studies from sort of more than 10 years ago, and I have to say, sort of since 2020, it feels like or even just before 2020, it's really exploded.
Yes.
And, for anyone that's listening that's new to this, that might be dismissed or have it questioned in a clinic if they're just not quite on board with it, or, by their GP, there's so much research to back this up, so all the time new studies coming out.
Absolutely. And research, and there's also, specialists.
Clinical data as well.
And practicing specialists who are educated in this field, who are working in this field. And so if someone feels like there's something wrong and they're being dismissed or they're not being given the answers, go talk to someone else.
Always get a second opinion.
Second, third. I mean, I got 10. But find the people who really want to help you. And let them help you. It's really important. But there are specialists, clinical specialists, who are very well educated in this field, who are more scientifically open-minded, I would say. It's about, are you willing to tread from the classic kind of medicine and clinic to the research a bit? I think that's where the new
kind of research.
Absolutely. So it is research.
I think for Jen and I, we've shared, and obviously now you're sharing as well, that we've come to this space because of our own health journeys. and our own experiences being women and with our own health. So I think usually what happens is it's those sorts of people who are then wanting to know more, isn't it? Who are then looking for more answers.
Absolutely.
Who will then start to research what else is out there.
Because no one, like I said, no one wakes up and thinks, I'm gonna
No,
vaginas.
exactly.
Like, I'm gonna go and research vagina. No, no one. They don't even teach you the word properly at school. So let alone.
And
to
so
think that you're studying.
your tests now are being used in a huge way within the kind of fertility area and the assisted reproductive, techniques, IVF, etc. But that wasn't the purpose of you finding ScreenMe and these tests, because like you've kind of mentioned already, the vaginal area is an ecosystem within itself. There's an immune system in there, like with the gut microbiome. We know that about 70% of the immune system is within the gut. And I was actually telling Jen that when I went to a conference in Dubai last year, and the first key speaker actually mentioned that she tests all of her patients' vaginal microbiome, regardless of age, regardless of where they are in the reproductive journey, regardless of whether they're, pre-menopause or post-menopause. Do you feel that that's something that women should be doing as part of a general health assessment?
You know what? I wish that it was free. And I wish that everyone could do it like they do their blood tests. It's about getting information about the body. And there's so much information to get from the vaginal microbiome about what's going on. We see sometimes a shift in that ecosystem when women are approaching menopause before anything else changes. That's how sensitive that ecosystem is to change in hormones. So your hormones impact your vaginal microbiome. Your metabolism or metabolic rate and everything else impacts your vaginal microbiome. Your gut affects your immune system, which then affects your vaginal microbiome. So women you can't isolate parts of us and treat it individually. It's a holistic nature of women. And I think the word holistic is not understood very well. Sometimes people say, oh, holistic health. That's just like wishy-washy stuff. No, when we say holistic, I'm talking about looking at the system as a whole rather than individual parts of it. I think every woman knows that her body is not kind of just her uterus working on its own, her gut on its own, her heart on its own. We all know that everything affects everything else. If we get stressed, our periods are late. We go fly and suddenly our gut stops working. Everything affects each other. And so this is the issue. And so the vagina, which has been ignored for a very long time, and the data that it actually has been overlooked, it gives a lot of information about a woman's health. And so if it was free and it was possible, and if if the clinicians and healthcare providers would all be provided free education on this field, then yes, everyone should get tested regularly just to see how they're getting on if something goes wrong. So women who have dysbiotic, which means unbalanced vaginal ecosystem, the immune system there
Can you just
broken.
explain the ecosystem?
Yes. So when we say the microbiome, what are we talking about? We're talking about all the microorganisms that live in a specific location. And everywhere we have a hole of some sort, there is a microbiome. In your mouth, in your nose, in your gut, in the vagina. And so the combination of those microorganisms we're calling, and that's an ecosystem. That's what I call an ecosystem, is how these organisms interact with each other and interact with the host.
And it's it's the bacteria and the
bacteria,
the viruses,
the fungi. But the host cells play a big part in that. And the microorganisms also play a big part in regulating those host cells. So when we say the vagina is an immune organ, what do I mean is there's been research that shows that a healthy vaginal microbiome protects you from all the potentially harmful microorganisms from growing. It's lactobacillus. If it's high, it kind of creates a barrier. And it makes a very hostile environment. It doesn't let other bacteria overgrow. And that's really important, overgrow, not exist. We don't expect no other organisms to be there. We just don't expect them to be dominating or overgrowing, taking over. And so lactobacillus produces this hostile environment to other microorganisms and also fungus, and keeps them in check. It also does the same for viruses. So there's research that shows that women with a healthy vaginal microbiome are less likely to get chronic HPV.
Yeah. That's why, when I have patients and it's in their history, HPV or abnormal cells on smears, always, I mean, like you, we always feel like we need to test. So many women I've tested where they're completely asymptomatic and we've picked up 4% lacto and a lot of other stuff. Yeah, because like an overgrowth of.
And we need more data in that field, right?
Yeah.
We've only seen like a little insight into it where there seems to be a relationship of how the immune system of the body actually clears out the virus and deals with it depending on the bacteria that are present there. So there is a crosstalk. There is lower level of inflammation, usually in women with higher lactobacillus rates. So again, there is correlations there. And if we could have all women tested, right?
Sorry, I just threw that question in there.
No, if we could have all women tested, if women could get tested once a year, once every 2 years, and if you see a sudden shift, a change in that microbiome, then you would be like, oh, okay, what's going on?
Yeah.
Yeah.
Because I think you also, the reason I pose this question is because, we do see a lot of asymptomatic women or even men, but, we'll get onto the fertility aspect in a minute, but infertility is a symptom.
Yeah.
But the other thing is, like you're saying, you hadn't been sexually active when you had your dysbiotic vaginal microbiome. So, these things take hold on us when we're vulnerable, when we're very stressed, when we're sort of really burning the candle at both ends, when we're not nourishing ourselves properly, And then I think that's where the kind of immune system element of it comes in as well, because if we have got a weakened immune system, then we are again more vulnerable, and that giving that exposure to these things then happening. So how does that dysbiosis then start to form or appear, if you haven't been sexually active?
$1 million question, right?
Yeah.
We simply don't know enough about this area.
Yeah.
And I have no problem saying I don't know. I wish more people could say I don't know and not think that that's going to ruin
it all.
and ruin them, or that this is, we just don't know enough.
But we know what to do in those, we know sort of next steps, but we don't always. I think that's even doctors,
no one knows.
No one, when I with my fertility journey, my doctor, they don't always have all the answers, like why you have immune issues going on, like. It's a big $1 million question.
It's huge, and that's okay.
Yeah.
It's okay not to know. Why did I have dysbiosis? I mean, we can make guesses. I'm a scientist. I can have hypotheses, and then we can go about testing them. But there's so many things that could cause dysbiosis. Your lifestyle is one of them. Your hormonal status is another. I mean, I had endometriosis. I probably had endometriosis since I was born. Who knows? But that could maybe play a part. Who knows? Did the chicken come first or the egg? Does my dysbiosis actually impact the progression of my endometriosis?
I think there's research happening around this, actually.
There is. Very new research.
Yeah, very new. Is it sort of is it the bacteria that's driving the endo or vice versa?
Yeah, exactly. So there's so many questions.
But we also know about like vaginal births, for example,
Yes.
and breastfeeding,
Yes.
and that's
and
not
antibiotic use. Antibiotic use, right?
That's not
Yes.
exclusive to the gut microbiome, is
No.
it? That is where it colonizes everywhere
exactly.
in the body. Yeah.
Actually, there is some research also looking at vaginal type. Well, the vaginal microbiome types. I say
The
we call them
CSTs.
the community state types,
Yeah.
which basically just means what your microbiome looks like, what bacteria is dominating, and so they categorize them into different types. And there is also some question around, is it genetic? Right. For example, different women may have different
And
species.
ethnicity.
Yes.
Ethnicity as well.
Exactly. But we don't have data, right?
Yeah.
We don't have data at all, especially when it comes to ethnicity.
No.
Yeah.
And different geographical locations. And this is the microbiome we're talking about. Of course, it's going to be affected by all of these different
your
ones.
test is available in different parts of
Yes.
the world as well, isn't it? Do you see differences in?
We don't have enough data to make
Okay.
to kind of make a claim on that.
Yeah.
You need a lot of data points to be able to see, because it's not just different. You can't even just call it ethnicities, right? You have to see where geographical locations, not just that. What about different parts of a society?
Yeah.
Different lifestyles, different
budgets.
Yeah.
It's complicated.
It's like any
Yeah.
aspect of health that we look at, all of these things
So
But
the
the
microbiome
key
come
is
into
it's-
consideration.
The point is, which I know we'll come back to, is like it's this personalization that it is very individual. It's,
no one has the same microbiome as you.
Yeah.
We hardly ever. I can't say we
No.
haven't seen. But in infections, you do, right? In full-blown infections. You'll get some samples that come back that basically have the whole microbiome dominated by one specific species of a non-lactose species, right? So it comes back and it's like 98% strep.
Yeah.
Well, we've seen a couple of those. But those are very atypical and very indicative of an infection. But normally you don't see two microbiomes who look exactly the same.
No.
It's very individual.
No, and we see it, a lot of reports ourselves, and we
Don't see the
we
same,
never
do you?
see
No,
never see
No.
the same. If we just go back
Yes.
to the vaginal, uterine,
Yes.
seminal,
Urine.
Yes.
microbiomes, could you just explain a little bit about the differences between those?
Yes.
Obviously one is male, and then
So we started with the vaginal, which is a shallow swab of the vagina. Some people, ask questions like, how far does it have to go in, etc. It's actually not that, it's not that sensitive or important, as long as the tip of the swab enters the vagina, because some people actually find it quite painful. And it shouldn't be. So you should never push against or feel like you have to be uncomfortable. As long as you do get in there, then you're fine. And then we have, so we started with the vaginal. Very quickly after the vaginal, we realized we're getting women with symptoms even, who need treatment or miscarriage or even infertility, I'm counting as a symptom, who need treatment. Now, immediately, my co-founder and I, we were like, okay, hold on. What if this is coming from the semen also? We're treating women, or we're recommending or sending these results to clinics and doctors, etc., or nutritionists and practitioners who are helping these women fix the dysbiosis. But what if there is also, a bacterial presence in the semen? And so we launched our seminal microbiome test.
And I think it's really important just to mention that, when we're thinking about things like BV, which is bacterial vaginosis, there's a high percentage of reoccurrence, and often it gets put down to like antibiotic resistance, but actually, like, we've got research to show when both couples are treated, the rates of recurrence drop significantly.
It blows my mind sometimes.
and IVF outcomes
Yes,
of
improve
course.
as well.
Yeah, it just blows my mind sometimes that, do I really have to say it? Like, do we have to put it in the Guardian?
We still have to talk
make
about
it
Golnoush
to make it
all the
real.
time.
Of
Male
course, you
fa-
can have bacteria
Yeah.
in the semen, and we were doing seminal microbiome testing for I think at least a year before there was the big paper and it was all over the news that, BV can also be in men. There are people who would go to their GPs with results of BV and say, what if my partner has it? And they would say that's impossible. This is called bacterial. These are BV bacterial vaginosis. The names we give things are important because they will make people think a certain way. If we're calling these bacteria, BV bacteria, well, it indicates that they can't exist in the semen, which is not true. They are not good in the semen. They are not good news, but they can be there and they can grow there. And so we were testing and we were seeing it very clearly. And then it was like, it exploded in the news. So sometimes things that are very obvious, I guess, need to be spoken about more.
Yeah.
And his semen can have bacteria. Semen is not sterile. Some people think it is. The number of men that I've spoken to are like, there's bacteria in my semen?
And a lot more as well. Let's just quickly, while we're talking about seminal versus vaginal, just quickly touch on the bacterial diversity of the seminal.
Yeah, so the vaginal, which we expect low diversity. We want it to be dominated by what we call good bacteria, but what we mean is lactic acid producing bacteria, which make the vagina an acidic place, make it hostile to everything else, including sperm sometimes. And so that's what we want. We want low diversity, high lactobacillus levels relatively to everything else. The semen, on the other hand, is a very new, semen microbiome is a very relatively more new field. We don't have even as much data as we do on the vaginal on the semen. It's even more of a black box, I would say. But from what we know so far is that it's a lot more diverse ecosystem than the vaginal when we're talking about health. Diverse semen microbiome doesn't mean an unhealthy seminal microbiome. However, the bacterial load in the semen, the total number of bacteria, is significantly lower in the semen compared to the vagina. And so that's actually important. Now, significance of these findings are yet to be clinically validated. This is a very new field. Research is just about coming up. There are very few specialists who can understand the seminal microbiome and work with it. But when we're looking at vaginal infections or symptoms, it's very easy to compare it to the seminal. If a woman is suffering from a specific infection, like Gardnerella or Privitella or Atopobium, and is being treated for it, well, I don't need to understand the seminal microbiome. All I need to do is to see if the same bacteria is there at a higher level, and so they need to be treated together, and that significantly reduces the chances of recurrence. And if you're treating for IVF, well, it's the same. Even it's the same concept. If the woman is being treated, if it's a heterosexual relationship, if the woman is being treated, and the man isn't, and you don't know if they share that bacteria, I don't say you have to treat them. I'm just saying be cautious and use protection.
But we have
until you get your IVF out the way.
Yeah, well, we do have research by Jonathan Ramsey and Tet Yap. It's a brilliant study that I often send to clients, talking about the impact of the genitourinary microbiome in men on sperm parameters and DNA, the quality of the sperm as well. So overall health of the sperm and therefore their fertility.
Yes, so it's a field that's up and coming.
Yeah.
And Jonathan, he's good,
yeah,
strong, resilient man.
Jonathan.
He's been
just
pushing
for context,
with it.
they're two of the leading male fertility urologists. Specialists within the UK, who we often refer quite a few of our patients to.
Yes, absolutely. And two of the few who understand the field when it comes to it. But yes, so other than looking at shared microbiome between man and woman, and interestingly, not all couples share them. So some people say, well, if we know that we're sharing it, well, if I check it, he probably has it, so why should we check? That's not true. Not all couples actually share. Why? $1 million question. But some do. And so testing is important. So that's for comparing vaginal and seminal and see if both need to be treated or one needs to be treated. But the other is male fertility on its own.
Yes.
And that
that's an
again
entire
is like,
field.
up until really recently, regardless of the seminal microbiome, even the whole male fertility, it just hasn't been looked at
Under the
Yes,
radar.
absolutely.
in terms of failed IVF or
No.
infertility or even
And that's-
miscarriage rates and increased miscarriage rates.
Entirely exciting
Overlooked.
field.
Yeah.
It's coming.
Yeah.
And
Yeah.
it's going to explode.
Yeah.
But it has been overlooked. When we started doing seminal microbiome, it wasn't necessarily to find abnormal seminal microbiome or related to fertility, because the data just wasn't there as much in terms of, I can't look at the seminal microbiome and say, hold on, yeah, this is causing the poor sperm. I can't do
No.
that, right? But when we did start, we did it so that we could compare it to the vaginal and make sure that women are getting the treatment they need, and also the men would get treated. And then it went, and that's when then suddenly we started talking about fertility and seminal microbiome. The papers were coming out, the data, and I guess we took a leap of faith when it came to this. And Jonathan was a good support in this. He's I feel like he's like a bit of a teacher or a mentor. He was very supportive, and so we said, you know what, even if we don't have all the answers, well, we've never had. ScreenMe hasn't been about knowing what's wrong and what to do with it. It's about giving access to the technology, providing the data so that everyone who wants help and everyone who's giving help can do it in a better way, in a more guided way. And so we started offering the Seminal on a wider capacity to urologists, andrologists, IVF clinics, those who are capable of looking at that data and thinking, okay, what can we do with this? Does this make sense? And we started seeing patterns. We started seeing things come out of it. The bacterial load, for example, diversity, presence of BV bacteria in semen. And it's an exciting field. There's my favorite paper in this field is one where it's a recent one where we're looking at DNA fragmentation and the seminal microbiome. It's really hard to do this research, by the way, because you have to control for so many factors, and it sometimes seems impossible. And really clever paper, because they didn't come and look at loads of people, which puts those different factors that you can't control for. They took sperm from one individual, healthy sperm, right? DNA frag was low, everything looked good, and they separate the plasma from the actual sperm. So the microbiome exists in the plasma, right? So they have the healthy sperm, and then they took semen from another chap who had really high DNA fragmentation and problems with his sperm as well. And again, they've separated the sperm from the plasma. So now we have plasma from a high DNA fragmentation sperm, and we have sperm that's very healthy, no DNA, very low DNA fragmentation. And they incubated the healthy, low DNA frag sperm in the plasma of the high DNA frag sperm.
So
and
interesting.
It's an amazing paper.
Yeah.
And it's so good because it's just so clear. There's not so many factors. It's clear, it's clean. And you suddenly see a significant rise in DNA frag in the healthy sperm. Of course, they did a control at the same time. They incubated the same sperm in plasma that has, his own plasma in essence.
Yeah.
And so there is controls, but it showed a significant rise in DNA fragmentation. Now the questions, this is the exciting research that's coming out, right? Can we make an immediate conclusion and say, this is what's causing? No, but we can tell that there's something going on.
Yeah.
There is an immune factor, there is a microbiome linked factor, there is the semen has other things in it as well, right? So there is some stuff going on in the semen that can increase DNA. Yes.
Yeah.
And so that's really interesting. And I think that's one of my favorites. I wish I'd done it.
Yeah. And just to mention,
it's so simple. But
Yes.
And DNA fragmentation is basically where the DNA in the sperm head gets damaged, essentially.
Yes.
And that can result in an increased risk of miscarriage. I mean, it increases risk miscarriage risk by 50% if there's DNA fragmentation. So like when it comes to fertility,
and again,
really
DNA frag is new
important.
as well, right?
Yeah.
Not all doctors
No.
actually
No.
do it or think it matters.
Well, we're on double-stranded now, so we're
Yeah.
but that's
yeah.
again another
Evolving.
conversation.
Exactly. So
Yeah.
there's also a difference of opinion in the fertility sector and between specialists on all of these things. But as a scientist, I find them exciting.
Fascinating.
I think it's amazing to have more data. I'm trying to conceive, and you know, for me, just knowing more. It's nice, but then you also have to be careful, obviously, because it can be really hard to have all this information and know what to do with it, and it can be like a rabbit hole, and sometimes you just think, okay, I can keep going, I can keep testing, so you just have to be on the cautious side as well, and make sure that you have the support you need and the right guidance.
That's really important, because like you said, it can be a rabbit hole, and I come across this all the time with like Googling and ChatGPT and all this stuff, and it is a minefield. I also had that experience with just struggling to conceive, and ScreenMe was part of that picture, because it was really, really important to test, and I double checked, and that was actually a few months before my transfer, but I had to put it to bed at that point because my consultant said he'd not seen a better microbiome. There was like nothing.
I remember yours.
There was nothing more I could do.
I remember yours. I was like, good for you.
You don't need to test this again.
No.
Like,
I think
you know,
I think it's a really good point to make, because we were talking off air about how sensitive your tests are, which just means they bring up a lot of data, don't they? And it's really, really important to do these tests with someone who can guide you through them.
100%.
And not everything with dysbiosis, and like you were saying, and it's really clear to make this distinction that dysbiosis and a full-blown infection are completely different, aren't they? And just because you see certain bacteria at certain levels, or sometimes your tests even identify things like mold.
Yes.
You know, so it doesn't mean that everything needs aggressive treatment necessarily.
Definitely
and
not.
it needs to be done as part of an investigative picture and
case taking.
and in the right context for the right person.
100%.
So all of these things, you know, people who I'm sure you're really wanting to go and do this test now, but it is really, really important to do it with someone who can guide you through.
So important. And, you know, people often say, okay, well, if I do this test, will you tell me what to do, what to take? And I'm, you know, I shoot myself, and like people are like, why would you say that? Why would you do that? I don't want anyone to buy a test just for the sake of buying a test. I don't want you to have this result that you don't know what to do with. I also don't want to lie and say that, we'll tell you what to do and it's going to get fixed. It probably won't, because it's not an overnight thing. Ideally, with these type of things, you will work with someone who is aware of the field, who's educated in it, who you feel safe with, who will work with you through a period of time, rather than a one-off thing. Who will take your history, who will know what's going on. These results need to be interpreted in context. You cannot have, even if you have this, you know, similar two pictures, you may not do the same thing with them. You know, you have to listen to the patient. You have to hear what their symptoms are, what they've gone through. There's so much to it. It's not a simple test and treatment.
So that's a full body. I think it's really important to mention, like you said, you use the terminology holistic.
Yes.
We talk a lot about functional. It's a full body approach. And I think people can be disappointed sometimes when, you know, they go in, they do the probiotics, they take the antibiotics, and then they wait, you know, the 3 months. And they generally, you know, I'm sure people are eating well. They're eating probiotic foods. They're doing what they feel is the right thing. But they test 3 months later and it's still there.
Sometimes it's worse.
Or it's sometimes worse. So I think it's really important just to labour the point that it has to be a full body approach.
Yeah. Absolutely. And you also have to just understand that we know when we're talking about the microbiome and reproduct, you're talking about cutting edge stuff. You know, this is where research is happening.
Yeah.
We don't have the therapeutics entirely down. We have the testing, I guess, down, but we don't know what to do with it entirely. There's like the antibiotics, there's the antibacterials, there is the probiotics, there is the lifestyle changes, all of that stuff. But we don't, and this is what keeps a lot of doctors away, right?
Yeah.
It's the idea that, well, I have the results now. What do I do with it? I can't just give her a prescription, a medicine, and she'll, what am I going to... Exactly.
Yeah.
And that keeps people away. I fight that all the time. I think it's important to give answers, even if we don't have solutions. And it's important to use all of this data to then fuel the research, fuel the therapeutics, so we can eventually, work towards having, the solutions, not just sit in the dark and say, well, because I can't fix it, I'm going to stay in the dark forever. I hope my children, if I ever have any, and I hope I will not have to face these things. I hope they'll have a better, easier ride than I guess we did. And we need data for that. And so these tests are important also in fueling that. And anyone who does these tests, I think most of them are aware that this is cutting edge. This is research. This is not to give you a quick fix. It's to give you information and hopefully help in paving the way to finding those solutions.
And we're finding out new information all the time, aren't we? Like recently there's been the links with, and this is what you might have been speaking about earlier with the fusobacterium, for example, with endometriosis, and finding that in the kind of vaginal microbiome, and whether, again, which one's fueling which, we just don't know, but we know that there is an association there now. So that's really fascinating. Go on, Jen, you were going to say something.
I was just saying, kind of cutting edge or kind of a bit unexplored. Let's just quickly talk about the uterine microbiome.
Yes, just going to go there. Yes, we were actually talking about before we met you as well. Emma analysis has actually been around for a really long time, hasn't it?
Yeah.
And actually that's something to really mention because that's part of the reproductive microbiome.
Of course.
And so if that's been around for a long time and we know the data's there and the research is there and that is actually treated in an IVF scenario, that gives us some standing for everything else that we're talking about.
I think the concept of infections causing issues with fertility is not a new thing at all. This has been forever.
When they do in like investigations, they give people antibiotics, don't they? Like
they sometimes do without any testing.
Yeah, exactly.
All the time.
Yes,
like if they're doing an internal on a woman, they will just give them antibiotics for that
even
reason.
Sometimes in IVF cycles, like it's part of my, I've got endometriosis, it's part of my protocol. I'm going to
take
have
the antibiotics.
Antibiotics.
Yes,
so there is something to
that.
that.
Absolutely. It's not a new or foreign concept to medicine that infections can cause issues for fertility. We know STDs do.
Yeah,
right.
Exactly.
That's an infection.
Yeah,
it's just an infection of a specific bacteria that we know or have researched. So infections having issues and causing issues for fertility has been a very long-standing
and preterm birth as well. So things like
100%
Group B strep is well understood as.
And even live birth rate as well.
Yes.
There's just so many elements that come into it.
So it's not new at all. It's just about how do we test for it? And then when we do test, what do we do with that data? How do we understand it? How do we analyze it? How do we process it? And the analysis has been around for a while. When we started the seminal microbiome, it's a swab of the semen. We don't actually use the sperm itself, as you just swab the semen and then we use the DNA from the bacteria. Once we were established with that, we had a lot of requests from just women, a lot of women who were asking about the uterine. And I am not a big fan of invasive procedures in general.
I was going to say emeralis is invasive, isn't it?
Yeah, and sometimes it's necessary. When you need to do an invasive procedure, it's necessary you do it. But but if I don't have to, I don't want to do invasive procedures. I mean, I didn't have uroplasma until I had an invasive procedure, and then I had uroplasma. So it's it introduces stuff. It's just uncomfortable. It's painful, and so we thought that why don't we start trying, making it available. that we test the period blood for bacteria. And the idea is, well, your endometrium builds up. Once your period starts, that endometrium sheds. And so whatever is in that endometrium also comes through with it, including bacteria. And so we started collecting that initial full flow in the first few hours of bleeding, and using that as a sample to look at the bacteria that's present. Of course, there's something to take into account, is that this is not a biopsy of a specific area of the endometrium. It's the entire kind of wall crashing down, coming through the cervix and out. So it is looking at the microbiome in that sample, and that includes the cervical microbiome perhaps also, because it does go through there.
And potentially vaginal?
It depends how you collect the sample. So ideally, if anyone can, we always say you should try and use a period cup.
Yeah.
That is the best way to do it.
Yeah.
Because you collect the blood.
Higher up.
It does sit higher up, and the blood just goes into the cup. It doesn't go through the vaginal canal to come out. So it stops it. But if someone cannot do that, and they just use a cup to collect the blood, then yes, there is potential contamination from the vaginal microbiome as well. That's something to always keep in mind. And so we launched with that, and that's something that's being used by practitioners, but also by clinics and specialists as well.
Yeah. How do we decide between vaginal and the uterine?
Yeah, good question. In an ideal world where you have loads of money at your disposal and it's not a problem or it's free, you do both.
You'd want to do both.
And because you would do them at different times in your cycle, and that's something else to keep in mind. Even though in a lot of women, the vaginal microbiome is actually quite stable, so it doesn't make huge shifts through the cycle. In some women, it does. Hormones, again, data, right? Why is it that the vaginal microbiome is going from one state to another just in a matter of weeks?
Or days.
Days.
Yeah.
So that's something else. So ideally, you would do one in your luteal phase, for example, the vaginal. And then you would use the uterine for when your period comes through. That's in an ideal scenario. You get an understanding of 2 points in the cycle. You also get an understanding of, is there a difference between the vaginal, the uterine? So you have the lower and the higher reproductive tract microbiomes. It gives you more information, more data to work with. But not everyone can do that. And that's completely understandable. I never push people to do both. So it's about figuring out which one is better for them. I would say if there's someone who has had a long history of vaginal symptoms, infections, problems, then I would definitely do a vaginal. But if there's never been any symptoms, any infections, any problems, any suspicions, and so on, then I would go for the uterine one. Some people do one and then do the other.
Yeah.
They do their vaginal. They do
that.
treatment.
Yeah.
And then they do the uterine after that.
Yeah, I think as well it's like, again, case history. If there's like recurrent miscarriage, implantation failure, then I'm kind of encouraging the uterine if they can't do both.
Exactly.
Yeah.
And sometimes it's, some people say, well, I can do 2 tests, but I don't know which 2, as in seminal, vaginal, uterine. It's so if they're definitely doing a vaginal and they can't do a uterine, I always say do the seminal.
Yeah.
Yes.
Because if there is something going on and you want to treat it, if it's there in the semen, well, it's just going to come back again. So vaginal, seminal, I would say if you can do 2 tests and you're doing the vaginal, then do the seminal alongside it.
Yeah.
But I wish you could just do all of it, and it wouldn't be expensive, and it would just give all the necessary information. But unfortunately, we live in a world where that's not possible.
And then urinary, that's sort of come about because obviously with some of this dysbiosis, you can have an increased risk of UTIs.
Yeah, so the urine we actually only started doing because there was urologists asked for it and practitioners asked for it.
I see it a lot in menopause, obviously, that
because
recurrent UTIs,
genitourinary
syndrome,
cystitis, all of those symptoms.
And then the lactobacillus levels really either fluctuating or dropping because of that change in estrogen or drop in estrogen. And
menopause is a fascinating field when it comes to vaginal microbiome. And it's amazing to look at women who actually also menopause and women who are sexually active and women who aren't sexually active.
Interesting.
And I find really interesting differences there as well. You tend to see more symptoms in menopausal women who are sexually active compared to menopausal women who are not sexually active. And
again, because they're getting exposed to the semen, which is more diverse.
But you know what? It's not just that. I think it's also the tissue itself, right? Yeah. So when you hit menopause, if your lacto comes down, there's inflammation. That tissue
there's atrophy,
thin, is atrophic. But it's not being touched. It's not being disturbed, and so you're less likely to have these flare-ups. But if it does get disturbed, then you start having these flare-ups. And so there's a lot going on.
Things like the recurrent UTIs can happen regardless, can't they?
I mean, I had recurrent UTIs when I had my symptoms were UTI symptoms. They weren't all vaginal. Very typical. Some like endo, itching, yes, but it was UTI symptoms, and there was high white blood cells, there was blood, but there was no bacteria growing. So we started the urine because there was requests from practitioners and from clinicians. We really only do them when practitioners request, they've requested for their patient to do them. That's more likely the case. And I really only ever tell people to do it if they are very symptomatic of UTIs. I don't think there's a pressing need to do a urine microbiome unless you do have recurrent UTIs.
Yeah, no, it's a good point. Can I just go back to the uterine again? Just very quickly, do you see then correlations between the uterine and the vaginal?
Again, so I think there's some research coming out in this as well. I don't think there's enough data to make an absolute conclusion on it. But yes, we do see correlation. Yeah. And then we see ones that just break the hypothesis. So there are some definitely, and then there are some who completely just go against all.
It's funny because you mentioned the ureaplasma, and that's what I was talking about with those kind of I guess just in case there is a proper word for it, antibiotics, prophylactic, and they actually give doxy, don't they? And it's for the ureaplasma. Yeah. And so when women have had internal investigations again, that seems to be the bacteria that then shows up and grows.
For some reason.
That's so bizarre, isn't it?
I never had it until I had a saline scan and a polyp removal. And but there is.
It's going to be a disruption.
I think sometimes
in the
with
bacteria,
polyps, my understanding just from working with my specialist gynecologist consultant was that polyps can almost like harbour bacteria. So then when you remove it, it's like a hiding place, isn't it? So again, there's all of that.
It's true. I mean, when I had this recurrent BV, when I removed my polyp, and mine was a cervical polyp, it wasn't a uterine. As soon as I removed that, complete change in my vaginal discharge, the recurrent BV symptoms disappeared. So that was really interesting for me as well. The other thing is, obviously, I never had spotting in between my periods. I never had any abnormal kind of cycle symptoms to indicate I have a polyp, quite a big one, huge. But I had quite long periods. I had 9-day, 10-day periods. Everyone thought that's because of the endometriosis. So that was put away, it's because of endo. As soon as that polyp came off, my periods have come down to 4 or 5 days.
Wow.
So again, there's so much that we need to do.
Yeah. It's interesting. I was talking to Jen because I work with a lot of young girls as well. So not necessarily, and older women. So from that whole kind of spectrum of women's health. And I was saying I notice I have a lot of patients coming to me with IUDs who have this increased dysbiosis, recurrent infections, just can't get rid of it.
It makes sense, doesn't it?
Yeah, there is obviously something there with...
You're putting a foreign body.
I mean, it makes sense.
Bodies, like the strings, I always find that there must be harbouring bacteria.
If you're trying they will time and time again. Like it's an ecosystem.
Balance,
and that's a sterile instrument, or that's a sterile thing that you're putting into a not sterile area.
place.
Yeah. And so again, there are going to be these changes.
It's with any ecosystem.
I think it gets discounted a lot, or, you know, that's not the cause, or that's not going to be affecting, or, you know.
I find it really weird when people say things like, that's not the cause.
Yeah.
How do you know?
Yeah.
Like, we have zero research or zero kind of data looking at these things.
Yeah.
And I think the best thing to say is we don't know if this can cause this.
No.
And that's about it. Really, when it comes to women's health, again, anything that we put into the vagina or anywhere, we have really no research about the implications of that on the microbiome of that area, and then the implications of that disruption on the health of that woman. So, you know, these are things we need to talk about.
But just to wrap, just as we sort of get to a close and want to wrap it up,
I know so quick.
Yeah, we have touched on some of the reasons for reproductive microbiome dysbiosis. So obviously hormonal, quite a big one, and that's because obviously estrogen provides glycogen, which feeds the lactobacillus, and that kind of helps keep.
And then the lactobacillus produces that lactic acid, which is
does.
what you were talking
progesterone
about.
as well. I mean, progesterone
and
is
the
involved.
pH of the vaginal microbiome is quite relatively low, isn't it, compared to seminal?
Oh my God, by
that
far.
acidity.
Because of that acidity.
Yes. So the vagina is like a gate to your pelvic floor and reproductive system. That gate is made up of lactobacillus, your little soldiers in a way, who are producing acid. They they make a hostile environment. They also form an actual physical barrier on the walls of the vagina to stop other bacteria from sitting in there and doing their thing. And they form bubbles around other bacteria, and they clear the bacteria out. Yeah. So they really work like a force, self-cleaning. So cleaning out the vagina. And they also...
That's why we shouldn't wash with anything, right?
Absolutely not.
Yeah.
And they also...
There.
Yeah, definitely.
Yeah.
And they also talk to the immune system.
Yes.
And they keep the immune system at bay.
This was like the next thing. So this is another bigger area, isn't it? The immune system in itself.
Yeah. So I like to see them all kind of hand in hand.
Yeah.
And that all affects your risk of infection. It affects your fertility. It affects your pelvic floor health and everything else in between. So what affects the how do we make sure the lactobacillus is there and it's strong? There's genetic factors to it. There's hormonal factors, so your estrogen, your progesterone balance, that's messed up in PCOS, it's messed up in endometriosis. Estrogen is important to feed the lactobacillus. Progesterone is important to make that feed available. So both of these, testosterone probably has, other all your hormones. Cortisol affects those. Yeah. So hormonal balance as an entire thing has its effects. Your diet and lifestyle, massive influence, because they affect your gut and they affect a lot of other things, and those things affect your hormones and they affect the tissue of the vagina itself.
And we think sometimes things can translocate as well. I mean, the gut and the uterine pelvic region, it's all very in close proximity.
Together,
absolutely.
If we pick up candida in the gut, we're often picking it up in the vagina.
Oh my God, uterine. Everything is so close.
Yeah.
And it's impossible, to think that, it won't. It's impossible. It's too close for it to not. So your lifestyle is important.
And vitamin D, I was going to say, I've seen low vitamin D in those that have got some of this bacteria, and it's like
the immune system link, isn't it?
Yeah.
And even the oral microbiome, and then we see that appearing where it shouldn't be appearing.
Your head starts going a bit funny at some point. You're like, okay, basically everything.
Yeah.
But your food, so
and
your lifestyle,
inflammation as well. I know you've touched on inflammation a bit today, but that as well, like whether you're having an inflammatory diet, lifestyle, all these other factors.
Yeah. So anything that affects your immune system.
Sugar is going to cause this kind of dysbiosis.
Immune system, and sugar feeds the wrong bacteria and the yeast.
Yeah.
So yes, your diet and your lifestyle will affect your gut, your immune system, your hormones, and that will in effect impact your vaginal microbiome.
Yeah. I always explain to my patients and clients as well that, wherever you get a bacterial infection, whether it's a respiratory infection, whether it's, somewhere else, a skin infection, that is your immune system, and that's inflammation at play.
Your mouth,
it doesn't mean just because it's appearing in your vaginal area that it's not everything else.
Everything.
That we talk
I was
about.
just, today I came across, I was reading a paper about the link between the oral health and seminal. microbiome.
Yeah.
So, and again, we need to remember, we're not saying that, for example, vitamin D is the cause of dysbiosis or oral microbiome is the cause of seminal. What we're saying is that there are links.
There's an association.
Yes, and all of this points to the fact that the microbiome health is very complicated. It's regulated nearly systemically by everything.
I was going to use that word.
It's a systemic health. And so it's also, and so you need to have different data points if you're going to work on it. And also that actually your microbiome results point out that are you okay systemically? Is something going wrong? And if something is off, it's the start of quite a long road, I think, an investigation as to what could be causing this dysbiosis.
And this also comes back to tying in the fertility aspect of infertility as well. It's not just your reproductive organs, is it? It is, again, your whole body. We're not carrying our eggs and our sperm in carrier bags outside of our bodies. They are a part of us. So everything that's going on within us, inside of us, will then be affecting our reproduction. And
we are
fertility.
A system.
Yeah. I think we're going to have to close.
Yeah, we are.
Thank you so much, Golnoush.
It's never enough time.
It's been an incredible conversation.
No, not at all.
What we just wanted to end with, what 3 pieces of advice would you give our listeners from kind of what we've talked about today? I think there's some key things that we could pick out here.
The first piece of advice would be find people who are educated and well-informed in the field, and ask for help so that they can guide you. Don't get lost in all of the noise. Find someone that you trust, that you have good chemistry with, who is educated, who is science-based, to help you navigate the space. I think this is really, really important. Second advice would be don't test just for the sake of testing. Make sure that you know why you're testing. If you come to us, feel free to email us or message us. We're really responsive, and ask us what to do.
Can I just say, Golnoush still looks at every single report that goes through ScreenMe. So that's dedication to the cause. So when she says this, she actually means it.
I do. ScreenMe is not a company that's just. It's a very small team that we keep running, and very intentionally, because we don't. We want to keep costs low, and we want to make it possible for everyone to get what they need and give the care and support that's needed. So do just reach out and ask for help if you feel lost. And third advice is, if you don't feel comfortable, if someone tells you nothing's wrong with you, or if something feels wrong, please, please, please get a second opinion, a third opinion, advocate for yourself. There are amazing doctors. Our healthcare system isn't a bad healthcare system. It's actually great. You just have to advocate for yourself sometimes and push and find the right people to help you.
Yeah, no, that's brilliant. Thank you.
Thank you so much for your
Thanks
time
for having
today. So just to wrap things up, we hope you liked this episode today and you found it useful. Obviously, there's a lot of information. We'll put summarize things in the show notes. We'll put where you can find ScreenMe, and more about the testing down there. Please do come back and listen again. Obviously, head to the show notes, share with friends, family, or colleagues who you think might benefit as well, just to really spread the word. And if you're looking for more support for the reproductive microbiome, then do get in touch.
Also, lastly, we just wanted to share, we do have a discount code to share with our listeners, so we'll put that in the show notes. So thank you again, Golnoush and ScreenMe, for that. That's very generous.
Oh, thank you very much.
And we've loved having you on today, and it's just a wealth of information that you have. And you really are, in the UK, you have been a sort of leading pioneer in the reproductive space. And I think you've done so much for a lot of people out there. So
I think we started, but I really hope others will join. And I think that the field will push and we'll have more answers and more care when it comes to women's health and also fertility care as well. I think we all deserve better. And I'm positive and optimistic that we are going to get better.
Thank you so much.